Good morning, everyone. My name is Monica Robbins. Welcome to our First Friday event. Thank goodness it's Friday, right? So today we are going to hear about hearing loss. As just a friendly reminder, I wanted to address a few housekeeping reminders. So video and audio has been turned off. If not, please make sure that that is turned off on your end. We would appreciate that. And if you think of any questions during the presentation, please don't hesitate to use the chat. We have individuals monitoring the chat and we'll do our best to ensure that those questions get answered. This session will be recorded and accessible at a later date for review. So towards the end of the presentation, it is our hope as well to be dropping in a survey for you to complete to give us some feedback in regards to the presentation and any maybe suggestions you might have moving forward. Accommodation services are being provided. Looks like Miss Emily Gordillo and Miss Bethany James will be assisting with ASL interpretation. And closed caption is also a feature that is available to you at the bottom of the screen. So you can click on that to enable if you'd like. So now a little bit of background about our speaker this morning. So audiologist Dr. Kelly Bogue, along with her husband, Tyler, co-founded Community Hearing Center in Jackson, Michigan. So after learning about speech language pathology and eventually audiology, Dr. Bogue earned a bachelor's degree in communication sciences and disorders from Michigan State University and a doctor of audiology degree from Ohio University. She completed her clinical fellowship at the Dayton VA Medical Center. And after graduation, Dr. Bogue worked in an ear, nose, and throat clinic and with a major hearing aid manufacturer before opening her own practice in Jackson. She values person-centered and evidence-based care delivered in a warm and inviting environment. Dr. Bogue is also a fellow with the American Academy of Audiology and the Academy of Doctors of Audiology and a member of the Michigan Audiology Coalition. She values the ability to help people hear their family, friends, and stay active with what they love to do by reducing their risks of health problems that go hand in hand with hearing loss. So with that being said, I'm honored to turn this presentation over to Dr. Kelly Bogue.
Thank you so much. I appreciate it, Monica. So as she mentioned, I am an audiologist and I own Community Hearing Center with my husband in Jackson, Michigan. I am appreciative for the opportunity to be able to speak with you today and provide you with more information about helping people that have hearing loss, options for treatment, and my goal is to make sure that this is the most informative presentation it can be to help you serve your clients. So something that I am notorious for saying to my patients is that I can't fix a problem if I don't know it exists. So that in this sense would be, I can't make sure that you are comfortable and confident in this information if I don't know that you have a question. So I certainly encourage that. You are welcome to ask me whatever you would like. If you don't feel comfortable asking something during a presentation or the presentation, I will be providing my contact information at the end. You're welcome to send me an email or give me a call, and I'm happy to discuss things further with you. I also have quite a lot of resources. So there's things that I'm going to mention that I'm happy to share with anyone, or I can send documentation to Monica. And if you guys have probably like a big group message that she could forward that on, I'm certainly happy to do that. But I just want to be as helpful as I can be for you guys. So today we're going to talk about obviously people that have hearing loss. We're going to talk about who are the professionals that are most suited to be able to care for these individuals and help assist them with whatever their needs may be. Options as far as different types of technology, including prescription and OTC hearing aids, obviously the kind of elephant in the room. What it looks like when somebody is going through an evaluation, what that process looks like, and touch a little bit about technology and accessories, as well as oral rehabilitation exercises. So to start with, when we are thinking about helping somebody with audiology or with hearing loss, we are thinking about audiologists as being the preeminent care provider in that spectrum. So audiologists in the event that you're not familiar with kind of our scope of practice, are trained professionals, healthcare professionals that specialize in diagnosing and treating, preventing, managing hearing loss, balance disorders, tinnitus, auditory processing disorders. And there's a whole lot of things that go along with that, the different types of devices that we have to help with that. So we are anything really that is related to managing the functions of our ear and hearing, and that encompasses a lot of things. In contrast, there are other people that do provide hearing care. Kind of the big two that we think about are really, you've got an audiologist, and on the other side of things, you have a hearing aid specialist. And there is a pretty significant disparity between the educational requirements for those two aspects of our field. On one hand, you have audiologists, right, who have quite a lot of educational requirements. So we start with a bachelor's degree, we go on and have our doctoral degree, which if somebody was previously practicing, they have a master's degree that's grandfathered in. Otherwise, an audiology degree would be a doctoral program, a PhD, or a combination of the two. You have a praxis, which is going to test our knowledge and make sure that we have the skills that are necessary to be able to work in this capacity. We also have a clinical fellowship year, and that's a pretty intensive year. So you are, really you hit the ground running. In my case, I worked, as Monica mentioned, for the VA, which was a great experience for me because you see any and all conditions. While it is something that kind of skews toward adults and older adults, you see all kinds of different needs for patients, and it's a very rewarding and also very challenging setting to be in. But there are significant educational requirements, the number of hours of clinical practice that we have to have before we even are able to obtain our doctorate. On top of that, obviously you have state licensure, and then certain states have other requirements. Sometimes they have to, or they require that people have a hearing aid dispensing license, which is kind of an old school thing that, is starting to go away because most people that have a doctoral degree don't need to have that additional license. Some states also require somebody to have what is called the ASHA Certificate of Clinical Competence. That used to be something that people felt like you needed to have in addition to licensure, but it really is something that is just purchased. If you have graduated from school and then you decide that you want to obtain your ASHA Cs, that is something that there's no additional requirements for. You've already met those requirements for graduation and for licensure. So you're really just buying a membership into an organization and then maintaining that yearly with CEUs, which you're already doing anyways with the state. So if you see that, it doesn't mean that there's any kind of extra special care that person is providing or extra education that they've decided to obtain kind of above and beyond. It's just something that some states had required previously. I am not a member of that organization, but as Monica mentioned, I am a member of several other organizations that are more specifically dedicated to working with audiologists and advancing our goals as healthcare providers. It's also something that we're continuing with education, just like most other fields. That's something that's going to go on throughout the span of our careers. Some people choose to go on and become board certified. There's different types of board certification that you can also obtain. In contrast, if somebody decides that they want to be a hearing instrument specialist, again, there's a lot of variety with what states require, but at a minimum, it is a high school diploma or a GED and on-the-job training. And that is very varied, the amount of experience that people get. They do also have to take a examination. So again, sometimes it's a licensure, like a state hearing aid dealer kind of license that they have to do. But there is a pretty significant difference in the educational background and the experience that those different providers are bringing to the equation. On top of that, as we'll get into a little bit later, there is now the option for people to do more with kind of a DIY approach. So buying hearing aids that are considered a non-prescription device that they are able to fit themselves. So we'll dig into that in just a little bit here. When we think about audiology services, not everybody realizes this, but there are a ton of different things that our scope of practice includes. Some of them I've listed here. The big things that you will probably encounter working with us on the MRS side of things would be if somebody's coming in and needing earwax removal, obviously diagnostic testing, and that can encompass lots of different things, but hearing testing, auditory processing, vestibular, so balance kind of evaluations, tinnitus. And then if we determine that somebody has a hearing loss and their goal is to treat it with devices, programming hearing aids and adjusting those hearing aids, providing assistive listening devices, also oral rehabilitation, and sometimes other things like specialty hearing protection. Depending on the field that somebody works in, they may be better served at having kind of a combination of things, depending on if they're kind of going in and out of different noisy situations. One of the big advantages to working with an audiologist is that we tend to be very focused on person-centered care as well as evidence-based practices. It is essential to be able to integrate the patient wants, their needs, their values into treating and helping them with whatever is going on in their life that has to do with our audiology focus. We know that the way that people identify with their hearing loss can change throughout their life, and it's important to be sensitive to how they identify and what they feel is going to be the best to meet their needs. When we think about somebody coming in to assess what's going on with the auditory system, there are things that we're going to dig into a little bit more deeper in a later portion of this presentation, but quantifying the hearing loss and qualifying the hearing loss, actually giving them some measurements that show them kind of where do they fall with regard to the actual numerical values that their hearing loss kind of pertains to, and some scores that we obtain for speech, both in quiet and in background noise. But more important than that, looking at how that correlates with their perceptions of how they're able to function and communicate in their everyday life, and what that means for them in terms of being able to be successful with the things that are important to them. We want to make sure that we are reviewing all the options. We're not just making an assumption that this person has hearing loss, so automatically, we want to give them hearing aids, because that's not everybody's goal. This is not a one-size-fits-all kind of approach. I always liken audiology to being like a puzzle. Every person is unique, and I think that's one of the things that is most exciting and fascinating to me, is that everybody comes in with different backgrounds and different experiences, and somebody may have very similar hearing loss, but their perception of it may be very different. One person might feel like, I have what we would qualify as like a slight hearing loss, but they're really struggling and they are ready to seek help. And I might have somebody else that says, no, I'm good. I really don't feel like this is a big deal. I have learned techniques to, maybe accommodate this in my everyday life. And we're just wanting to kind of monitor and try to prevent further loss. So we don't want to make assumptions. And something that I think has happened a lot in the past is kind of putting people into a bucket based on where they fall on an audiogram. If somebody has a quote unquote normal hearing loss or a slight hearing loss, like I mentioned, a lot of times in the past, providers would say, no, you're good, right? Things look good. We'll see you next year for a checkup, or 3 years, or whatever that time period is. And that does not address the patient's needs or their perception of how their hearing loss is impacting their life. So that's really important. Not only do we want to make sure that we've given them those options, we want to verify what they've chosen to do. So if somebody decides, hey, I have a hearing loss, I am interested in pursuing treatment with hearing aids, we want to verify that when we are fitting them with those devices, those hearing aids are doing what they're supposed to be doing. So we'll touch on that a little bit more later as well. So if we are contrasting that with the over-the-counter devices, the kind of DIY approach, I do understand the need for giving people more options. Obviously the goal for a over-the-counter hearing aid is to increase accessibility for folks, because they're hoping to have something that maybe is at a lower price point that would still be helpful to them. And that is certainly something that is important. A lot of people have become more and more tech savvy, and that continues, as technology is something that is integrated into our lives from the get-go. My kids have never known a time where they haven't had, access to technology. Granted, we don't give them the ability to just plan things, ad nauseum, but, they start using iPads or tablets right from the get-go. As soon as my oldest started in young fives, they start doing various programs right on the iPad. In contrast to us, who, I didn't have a cell phone, and it was a family phone until high school. So that is definitely changing with younger generations. And I think it's something that we need to be mindful of. We can't, kind of put our heads in the sand and say, the landscape isn't changing. We can just ignore this. The bigger thing that I think really makes a difference is not remembering to differentiate the care that an audiologist provides with regard to being able to, I'm sorry, my husband just walked in, being able to help them with needs beyond the widget, right? Like if you only focus on a hearing aid, you are ignoring so many other aspects of what's important about hearing care. So going back into the DIY kind of option for folks, when we think about the OTC kind of regulatory effect, the FDA's final rule on this categorization of devices went into effect October 17th of 2022. And they did have some various parameters, of course, that are designed to help people know who are these devices for, and when they are looking at purchasing them, they have to have some labeling standards on them. So these are designed for people who have relatively normal cognitive functioning. They're able to make these decisions for themselves. We're not worried about the ability to understand the implications of a device that might be inappropriate for somebody that could potentially cause more damage to their hearing. They are air conduction hearing aids, which when we get into testing will, if you're not familiar with that term, make a little bit more sense, but we are utilizing just the normal auditory system. It means it's not something that's implanted like a cochlear implant or a bone anchored hearing aid. And they are ideal for people who have, or maybe not ideal, but they're ideally designed for people who have a perceived mild to moderate loss. And the key word there is perceived. Anybody who has worked for any duration of time with folks that have hearing loss knows that our perception a lot of times doesn't really line up with the reality of what we're missing out on. It is important to, like I mentioned before, consider where people feel like they're having difficulty with, but sometimes people don't realize all that stuff that they're really missing out on. So the challenge with that is that there is no requirement. Oh, I'm sorry. And there's also for people who are 18 and up, right? So these are not for children. The challenge is that there is no medical requirement. There is no audiology evaluation requirement. And that was something that was thought of as improving access because it was described as a barrier to healthcare. I find that frustrating personally because you are taking out a really important part of the equation. Certainly having access to healthcare is important, and trying to be able to do that in a way that doesn't require people to have to go through multiple hoops to be able to access that. But I feel like that's diminishing the importance of a really good evaluation, making sure that the ear is thoroughly assessed and that there aren't any contraindications or other underlying medical conditions that need to be evaluated. The range of these devices is pretty interesting. So, the goal was to create something that was more cost effective. And certainly there are devices on the lower end that exist. You might find some for $50 or cheaper. They're generally not very good. And they range, I've actually seen research that's shown that there's ones out there up to 6,000. I personally have not encountered that, but I've definitely seen them up into the $3,000 range. The average cost for most of them out there is going to be about $1,600 for a pair. So yes, there is cost savings relatively, but not really a ton of difference in the grand scheme of things for where a lot of people are going to fall compared to even more of a kind of an introductory level of a prescription hearing aid. There's also, like I mentioned, regulations on packaging. So they need to be able to be labeled for the output maximum for the hearing aids or the devices, because we want to make sure that patients aren't inadvertently causing more damage to their hearing, as well as the maximum insertion depth. So how far they're sitting down into the ear canal, again, trying to make sure that they're not going to inadvertently cause damage to the ear. When we think about those devices, they really fall into two categories. So we have self-fitting devices, and then we have non-self-fitting devices. The self-fitting devices are generally subject to more FDA scrutiny. They are utilizing technology, sometimes software, that lets the user input information. So being able to utilize that coupled with like a self-fitting strategy. Sometimes they will let a user put in a hearing test. So if they've come to an audiologist, had a hearing test, they can take that information and put that data in. Sometimes they have to do a test through the device and, kind of measure those thresholds with earphones, and then take that information into consideration when trying to fit themselves. It does have the advantage of them being able to kind of do them on their own. So if it's a challenge for a patient to be able to get into an office based on like their schedule or restrictions on being able to be able to travel, do you have a ride if you can't necessarily drive, or, if you don't have access to public transportation. So there is an advantage in that regard. But it does require that patients do this themselves. So they are the ones that have to make the decisions about what is going to be the most appropriate for their lifestyle, and how do they get them in? Do they choose the correct tips? How do they clean them? How do they charge them, which is not generally as hard? How do they hook them up to Bluetooth? And make adjustments by Bluetooth. And if the Bluetooth isn't working, being able to troubleshoot that. And certainly there are folks that are very tech savvy and can do that, but that is quite a lot to put on somebody that doesn't have any kind of background with that information. And the non-self-fitting, we're looking at there being some pre-selected profiles. So typically, again, in that mild to moderate range, there's going to be different options for the amount of gain or how loud the hearing aids can be that patients can kind of switch into, listen, see what their perception is, see if they need to make kind of an adjustment for that. So those ones are a little bit more, user-friendly to somebody who doesn't necessarily feel comfortable going through all those aspects of a fitting themselves. Most OTC devices do require the use of a smartphone or a tablet. So sometimes that can be a little bit limiting to patients that don't have, obviously, that technology. And typically they are iPhone based. So there is definitely more of a skew to you needing to have that type of technology to be able to do some of those different programming options. One of the things that people also don't necessarily think about is the return policy. Sometimes that can be very limited or challenging. I have a patient who her children bought her a pair of OTC devices, and she wasn't confident. She just didn't feel comfortable trying to set these up for herself. She didn't really like them. She came into us and we found another solution for her, but she wanted to return them because, she's like, I don't want my kids to be out this money. And she's still waiting on getting reimbursed from that. She had to go through quite a process, and these ones happened to be purchased from China. So she had to send them back, and just waiting to hear back on all that can be a little bit stressful for folks, or maybe they're outside of that period where they can't at all. And sometimes that cost is, pretty darn high. So that definitely makes a difference. I think there's a lot to consider there, and people have to really be able to do the research to determine whether or not that's something that they want to take on for themselves. I kind of have touched on this a little bit, but when we're thinking about some of those risks and challenges of utilizing a DIY hearing aid, the biggest, in my opinion, is not having a medical or an audiological evaluation. What kind of potential abnormal anatomy is underlying what's going on with them? Is there some kind of pathology that is maybe going undetected and potentially untreated? Something that could be potentially medically treatable or managed that we're just, missing out on. And then, like I mentioned, the ability to set them up yourself, having to have that skill set. And I had a patient, I'm just thinking of another one here, that we had kind of an interesting interaction. He started seeing me, it's been about 1.5 years now, and he was a really big fan of Eargo, which is one of those OTC hearing aids. And he thought he was doing really well with them, but he'd gone through multiple sets. I mean, he'd spent thousands and thousands of dollars over just a short period of time, and was like, yeah, I don't know that this is really cutting the mustard here. So he came in and we discussed his options, and he really wasn't a good candidate for those hearing aids. His hearing loss was above what that fitting range really should be. And he wasn't really happy with a lot of the different things that he wasn't able to do in his everyday life. He wanted something that was discreet. He wanted something that was in the ear and rechargeable. And we were able to meet those needs. And it's a night and day difference. He's like, I had no idea all the things that I was missing out on, and what a difference it makes to have something professionally fit. So that guidance, I think, is a huge, huge thing that people are overlooking. Not having somebody that has that expertise to be able to help you navigate that process and continue to accommodate changes in your life and your hearing is a really important aspect of having that hearing care professional be a part of that process. Regardless of the decision to go with a prescription or an OTC hearing aid, we really do recommend having a good analysis of the auditory system. So that's what we're going to talk about next. When we're thinking about this is where it's really, really important to have, and it's essential to have an understanding of the ear and how it works. You know, there's different aspects of our ear that can contribute to hearing loss. And so you're looking at a picture on the screen there that kind of breaks things down. Generally speaking, we think about dividing the ear into sections. We've got our outer ear, which is our pinna ear canal up to the eardrum. We've got the middle ear, getting into those bones, those 3 middle ear bones, our ossicles, up to the point of the inner ear, and then taking that information up to the brain. When we think about hearing loss, there are kind of 2 buckets that hearing loss falls into. We've got congenital conditions, which are present at birth. They compromise genetic as well as non-genetic conditions. Sometimes that can be a complication at birth. It may be a nervous system disorder. There may have been an ototoxic, which is poisonous to the inner ear medication that a pregnant person received. And so all of those things, as in addition to others, maybe alcohol abuse or other kind of drug abuse that could certainly end up causing a hearing loss, compared with acquired hearing loss. So that is something that's occurring after somebody has been born. And again, huge range of things that we see. This is the most common type of hearing loss. The most common of those acquired losses is related to noise exposure. But again, you can have an ototoxic hearing loss. You could have somebody who had frequent ear infections, especially frequent ear infections that went untreated. They can have a condition of the middle ear called otosclerosis, where it's basically an overgrowth of the bone that doesn't let the ossicular chain, those 3 middle ear bones, be able to function like they should. So there's a lot of different things that can contribute to both of those categories. Within them, though, we break hearing loss down into different subtypes. So the main 3 are sensory neural, conductive, and mixed. Sensory neural is where damage has occurred to the inner ear and or the acoustic nerve that takes that information up to the brain. Again, the most common type of this would be related to noise exposure. It is a loss that is generally permanent. So sometimes there can be conditions where the loss is not permanent. Somebody might have had a sensory neural loss as a result of an ototoxic exposure, and that left their system. For instance, if they were maybe exposed to an aminoglycoside antibiotic, when that left their system, they may no longer have that severity of hearing loss. Or maybe they started treatment for something, and again, kind of same idea, a medication caused a loss that later on, they were able to have reversed. Maybe they had a sudden hearing loss. So a sudden hearing loss is a very challenging thing because it's almost always idiopathic. We don't generally know what's causing it, but if it is related to a bacterial or a viral infection in the inner ear and a person is treated right away, which looks like steroids, either administered orally or through an injection in the eardrum, sometimes we can see some reversal of that. So sometimes sensory neural hearing loss can be reversed. There's various conditions there, but generally it is something that's permanent. A conductive hearing loss, on the other hand, is where there is a problem with either the outer or the middle ear. Sometimes those are very easily fixed. Earwax, the thing that everybody hopes is causing their hearing loss, which is not generally the only thing that's causing the hearing loss. But, sometimes that can work like a plug in your ear. I had a lady yesterday, and we were amazed at just these amazing amount of earwax that we got out. And she said, I can't tell you what a difference this makes. She was having kind of a reverberant effect inside of her head when she was talking. She would bend over and she would feel kind of like dizzy, and there would be kind of a shift in her perception of her hearing. So those are nice because that's an easy win for people to not have a long-term hearing loss. But there are some that are more significant. If there's a problem with the eardrum, if there's a hole in the eardrum, if there is a disarticulation of the bones in the middle ear space, someone has been in an accident and they suffered head trauma, sometimes those bones may not be connected as they should be. And so again, there might be another option for be able to treat that. For instance, having a surgery, maybe putting in a prosthetic bone. So there's a lot of things that could potentially contribute to that conductive loss. Someone could also have a mixed hearing loss, right? So they can have a combination of the two. So you can have somebody who had Maybe they had an injury where they had a hole in their eardrum, but they also have worked in a noisy setting where they have noise-induced hearing loss. And so they've got a couple of different things going on at the same time, and that's a mixed hearing loss. Beyond that, we also have, oops, I'm sorry here, guys. We also have central hearing loss. So a central hearing loss is a little bit more of a complex type of loss. That is something that is occurring as a result to a change in the auditory pathway or the auditory cortex. And it can manifest from a variety of different conditions, various neurological conditions, a brain injury, degenerative diseases. Some of the two that we think about or that are kind of subsets of this are auditory processing disorder and auditory neuropathy spectrum disorder. But they are ones where a lot of times people will have normal hearing, meaning that the sound is able to reach the brain, but it can't be processed in a way that they're able to utilize speech. And that's a really frustrating thing, because for those folks, a lot of times hearing aids aren't super helpful. There's other kinds of communication strategies and different types of assistance that we need to provide. Sometimes hearing aids are, for folks that have auditory processing disorder, they can sometimes be more beneficial to have hearing aids in conjunction with other types of therapy. So when we're thinking about determining the kind of hearing loss that somebody has, we're looking at the audiometric evaluation. And this has a lot of different components to it, and the components vary depending on what the needs are for the patient. So I'm going to touch on kind of the main type of evaluation, what it looks like that we would provide for patients. Obviously, there are special tests that we sometimes have to integrate. If somebody has tinnitus, for instance, so they have ringing, buzzing, chirping, some kind of abnormal noise that's happening in the brain, then there's going to be other kind of layers to that exam. If somebody has balance problems, then having vestibular testing be something that's added on. But, a general audiometric evaluation is going to look like this. When somebody comes in to see us, the first thing that we're going to do is we are going to sit down with them and we're going to talk about their history. We're going to talk about, what kind of exposures they've had. Are they having, any pain, any pressure, any fullness, any drainage? There's so many different aspects of things that might be making hearing loss challenging for them, but also things that we need to consider when we are thinking about other options going forward. So getting a really detailed history of their audiological symptoms and also their hearing or their medical symptoms is really important. There are a lot of comorbid conditions, which we're going to touch on a little bit later, that occur with hearing loss. So if I know, for instance, that somebody has diabetes, we know that people that have diabetes are at a higher risk of having hearing loss. Things that change our vascular system, things that change blood flow, generally correlate with an increased likelihood of having hearing loss. So for me to ask those questions, that's really important. Knowing what kind of medication somebody takes, going back to what I mentioned about ototoxicity, I try to always touch on this with patients because there are many categories of medications that have the potential to cause hearing loss, tinnitus, balance problems, or a combination of the three. For some of those, they're very common things. There's certain types of blood pressure medications. There's a category called ACE inhibitors, water pills. And for a lot of people, those go hand in hand, blood pressure meds and water pills. NSAIDs, so there's things that people frequently take that can contribute to some of the symptoms that they may have. It doesn't mean they will, of course, have that side effect, but if we're aware that that's going on, that gives us more information when we're trying to do this differential diagnosis for what's causing this hearing loss. We also want to assess patient goals and their motivation. I always ask all my patients, before we get started today, do you have a goal or an outcome that you want to make sure that we address? Because I want to know that we're on the same page. Like I mentioned before, I don't want to assume that somebody, has hearing loss and therefore automatically wants a hearing aid, because that might not be the case. So I want to be sensitive to what is important to them and what they are wanting to be able to achieve. I also want to assess what is realistic if they are considering technology. What does their manual dexterity look like? What about their visual acuity? Do they have a support system? Do they have prior experience? Because sometimes people are coming in with maybe a negative experience, or they've heard from family or friends that, hearing aids just don't work or whatever it is, I want to make sure that I'm aware of what those kind of thoughts and expectations are so that I can make sure that I address them appropriately. Along with that, I think it's very important that we conduct subjective measurements of a patient's perception of their hearing. So that looks like different kinds of inventories, like the hearing handicap inventory. If somebody has problems with their tinnitus, the tinnitus handicap index, if somebody is coming in and they have maybe other risk factors for other conditions, maybe we need to do a depression screening or a cognitive screening. There's lots of different elements that we need to consider. Looking at auditory listening, fatigue, listening effort, those things are really important, especially if we suspect that there might be an underlying auditory processing condition. So making sure that we have all of that information is important. And then we can utilize those pre-outcome measures and compare them with post-outcome measures, depending on what those treatment options are. Did we achieve the patient's goals? Are we seeing an improvement that we can measure based on their perception? When we are getting into kind of the nuts and bolts of the actual examination itself, after we're done with that history, the first thing we're going to do is look inside somebody's ears. So we want to see what's going on inside there. After we take a look in there, maybe there's wax that needs to be removed. Maybe there's something that is a contraindication to us moving forward. If we see, hey, there's some kind of a pretty significant problem that's happening here where I want you to see an ear, nose, and throat physician first, then we want to make sure that they're doing that before we go any further. We also want to take a look at how the middle ear is functioning. And there are a variety of tests that we're able to do this. A basic one is what's called tympanometry. We also look at acoustic reflexes and decay. So we're wanting to see, how does the ear move in response to sound? How does the eardrum move, the bones in the middle ear space, the stapedial reflex, that pathway that's taking the information up to the brain, because all of those things give us clues about what's going on with the auditory system. When we're done with those, then we want to go and take a look at their hearing test in the booth. So, we want to do testing that looks at their air conduction and bone conduction test results. So that looks like, putting insert earphones in the ear, or circumoral, where they go on top of the ears. Also putting a piece behind the ear called a bone conductor, where we're bypassing the outer and the middle ear and testing the inner ear directly. If somebody has fluid in their ear, if they've had an ear infection, or if they have a tube in their ear because that ear infection was treated with tubes, doing that test shows us to what extent their hearing is kind of being artificially worsened by having something going on in the middle ear space. So it gives us an idea what's the inner ear looking like, and then any other kind of layers on top of that. So in case you've never seen inside of an ear before, this is a picture of a really beautiful, healthy looking ear. I frequently will look at people's ear and say, oh my gosh, your ear looks so beautiful. And they're like cracking up because nobody's ever given them that compliment before. It's something that only a nerdy audiologist gets excited about, but this is a beautiful ear. If we look in somebody's ear and we see that maybe there's not something, there's something that's going on that's maybe abnormal, right? So on the left side, we're seeing a wax blockage. In this case, this person has so much wax in there, like my patient from the other day, that we're not able to visualize the eardrum. So that's a problem. That wax has to come out before we want to do a hearing test, because it's not going to give us an accurate idea of really that true hearing perception. Depending on the severity of the blockage and depending on the comfort of the practitioner and what they're trained to be able to do, sometimes it's wax that's removed by them. Sometimes they need to see an ear, nose, and throat doctor, especially if it's really deep and it's really impacted. On the right side, we are looking at a picture of an eardrum that has a hole in it, right? So we know right off the bat, we're going to be expecting some degree of a conductive loss no matter what, because sound is not able to transfer across the eardrum as it would if there were no hole in there. So we're already looking at, kind of what we're expecting there. When we are completed the evaluation, for our office, we come back and we take a look at the results right then. So we are going to show the patient, what those test results look like. Again, kind of quantifying and qualifying hearing loss. But with this, we're looking at putting that information on this chart here. Is called an audiogram. We're looking at a measurement of, where's their hearing at in terms of how loud or how soft things are, as well as the frequency range. So this audiogram is called an audiogram of familiar sounds. And this is helpful for a lot of patients because the terms that we use are not the most descriptive, and they don't really relay what the hearing loss actually equates to. If you see normal or slight or mild, you think, okay, well, I'm doing pretty good, right? But if you actually look at somebody that has a mild or a slight hearing loss, that would be equivalent to somebody that has normal hearing wearing earplugs all the time, which is very challenging. I remember in undergrad, that was actually an experiment that one of our professors had us do. Take a pair of foam earplugs, put them in, wear them. And they wanted us to wear them, for a week, but like all day, wear them to class, wear them when you are hanging out with your friends, wear them when you are at work, wear them when you're on the phone. It is extremely challenging. So it is kind of a misnomer when we use something like a mild hearing loss and tell somebody that they don't have any problems, because that actually does cause a lot of difficulty for a lot of people. But this lets them see kind of where do those sounds in everyday life fall? Where are we looking at in terms of speech sounds? A lot of people that have a noise-induced hearing loss, and really just hearing loss in general, have more difficulty with the high frequencies, which is related to how the inner ear is structured. If you were able to kind of remove the cochlea from the inner ear and like crack it open and stretch it out, it's arranged tonotopically with high frequencies on the outside edge. And then as it winds in toward the center, they become lower and lower frequency. So if you think about sounds entering the ear, the first sounds to be impacted are the high frequencies, which is why we see a lot of people that start with a high frequency hearing loss. And then as it kind of goes back toward the mids and lows, a lot of times it gets better. So this lets them see, oh, you know what? This makes sense why I'm having difficulty with somebody that has a higher pitched voice. I'm having difficulty hearing this child speaking, because a lot of times children's voices are higher pitched, so they're not going to be as easy to understand. If we're looking at even just kind of the ends of words that have similar sounding consonants, one that we think about would be, is the word depth with a P? Is it deaf with an F? Is it death with a TH, the sound? Those voiceless consonants are really challenging to be able to differentiate between. And if you're missing those, it's hard to fully understand what somebody is saying to you. So we not only want to measure that and share that with them, we also want to connect that with real life implications, what that correlates to, like I mentioned, for their life, so talking about like different kinds of voices that they may have trouble with, or noises, how that impacts their function in terms of different work environments. And then we want to take those pieces of information and integrate them into whatever kind of treatment plan makes sense to meet the patient's goals. So that looks like, a lot of different things. If somebody is interested in hearing aids or different types of accessories, we want to explore the different styles of hearing aids. There's a huge range from little teeny tiny ones that go in the ear up through ones that sit behind the ear and may have a mold that anchor them down inside, and what's appropriate. Looking at the hearing loss, not every hearing aid is appropriate for every hearing loss. I also value longevity. So I want to pick something that is ideally going to give us room for adjustment if the patient's hearing loss changes. We don't want to say, oh, no, you picked this device and 2 years down the road, your hearing has changed and it's no longer appropriate for you. So I really look at a lot of those different factors with their history and their, kind of ongoing exposures and where their loss is at, to make sure that we're trying to consider all that and choosing devices that are most appropriate for them. We also want to think about, functionality. Are they somebody that needs onboard controls, or do they want to utilize Bluetooth? Do they need a feature like a telecoil so they can be able to tap into a loop system? Is rechargeability something that's important? Depending on the kind of hearing loss that somebody has, they may have an asymmetry. They may have one ear that they don't have any usable hearing in, and the other ear is good. So we might have to look at devices that take that signal and send it wirelessly to the other ear. And that might also be an ear that has hearing loss. So there's a lot of different things that we try to get into. I do have a link for one of the hearing aid manufacturers called Starkey. They have a really cool feature on their website that is a hearing loss simulator. So if anyone would ever like to take a look at that, it's a really interesting thing. I remember doing this in one of my grad classes, and it wasn't Starkey's, but it was kind of a similar idea. They had this audiogram and they showed, kind of different hearing losses on there. And then they also showed us lyrics. So we were kind of getting a visual as well as kind of hearing what was going on, but it was giving us a simulation for what it would sound like at those different levels of hearing loss. And with the lyrics, you guys might have seen this before, it shows you the lyrics to a familiar song, and they kind of do it in reverse for this particular presentation, where you see like they're all faded, they're kind of patchy, and you can see like, maybe a couple letters here and there. And that's, replicating somebody that has, or mimicking somebody that has kind of a more severe hearing loss. And then as we go back down the line, so getting better and better with, regard to their hearing sensitivity, more and more of that picture is filled in. And it just kind of helps you to visualize what a significant difference it makes if you're not hearing all those pieces. They're like, okay, does anybody know what song this is? No, I have no idea what song this is if I'm only seeing like a couple of faded letters here and there on the page. And then eventually you start to get a better idea of what it is. But I think that simulator can be very helpful for family and friends, maybe even an employer that doesn't really understand the impact that that hearing loss can have on that individual. We also want to think about, like I mentioned kind of before, medical intervention, referral. If I look into somebody's ears and I see, oh, there's a fungal infection, there is drainage, there's fluid, there's something that looks like an abnormal growth in the ear. If I find that in testing, there is a suggestion that they may have otosclerosis, like I mentioned previously, there's lots of different things that can make a difference that we need to refer on for. They may have had a sudden hearing loss. They might have a unilateral hearing loss. I mentioned tinnitus before. So if somebody has ringing in their ears, if that is something that is really on one side versus the other, or if it has a pulsatile aspect to it, those are red flags that there may be something else going on along the auditory pathway that needs a more in-depth medical look at it. They might need to have an MRI or a CT of the brain. So making sure that somebody knows these potential complications that could be going on and knows when to refer is really, really important. When we think about our hearing, the brain is pretty amazing to me, and hearing occurs really across the brain. It's fascinating because, when we think about the different parts of the brain, the auditory cortex is contained in the temporal lobe, but we know from functional imaging that that's not the only area of the brain that is stimulated by receiving that audiological input. It's something that makes a huge difference when we think about our brains not receiving that stimuli. And hearing loss is actually the most common neurological disorder. That's according to the World Health Organization. About 360 million people worldwide have a hearing loss. And when we're thinking about the way that the brain is receiving that information, it's really interesting because the areas that are being stimulated when somebody has normal hearing, when your hearing gets worse, what can actually happen is that other resources in the brain, other areas of the brain can kind of cannibalize those resources that were previously allocated for hearing. So it literally makes it even more challenging. It's not just the element of you've literally lost the hearing, but you're also losing some of that cognitive function because the other parts of the brain have kind of taken it over. But going back to functional imaging, we know now that if you are giving the brain that stimulation back, if they're hearing those sounds again, the auditory information can actually be regained, which is amazing to me that your brain can do that. That element of neuroplasticity, I think, is really, really fascinating. So it is important that we know that, appropriate stimulation can make a big difference in patients being able to regain those functions. When you have hearing loss, it's impacting so many different areas. It makes conversations more difficult to follow. It makes people more tired. There's literally an element of auditory fatigue. At the end of the day, people will frequently say, I am more tired if I really think about this because I've been working so much harder. I'm really, really, really having to pay extra attention. I'm having to look at people's faces, look at their lips to get facial information and lip reading cues. I'm trying to kind of fill in the gaps. I'm being cognizant of, where I'm at in all these different spaces so that I can try and put myself closer to a sound source or, really try to help improve what we call the signal to noise ratio. So we want to get the speech significantly raised over the noise that's going on around us. So they're perpetually having to work on accommodating environments to help them be able to understand what's going on. And that definitely increases our mental load, right? The capacity that is left over for other things can be diminished because of how much harder we are working to kind of overcome when you have that significant amount of hearing loss. And that really makes a big difference in our functionality throughout our life. I mentioned before that there are a lot of comorbid conditions that occur with hearing loss or can occur with hearing loss. It doesn't mean you necessarily will have all of these, but I mentioned before diabetes, heart conditions. It's interesting because certain types of tinnitus can tip us off that somebody may have some kind of a cardiovascular issue. We know that if somebody has hearing loss and it goes untreated, they are more likely to begin to withdraw from social situations. Not everybody, but a lot of folks that are really socially active, if they are in situations where they can't easily communicate, they're frequently asking for repetition, they're kind of trying to fake it out and help people or make people think that they know what's being said, or they're a part of a conversation, but they're not really. That is something that can be very challenging and can cause them to sometimes not want to be a part of things. Now, not everybody is that way. They might not have a problem with that, but I do have a lot of patients that tell me that, well, I just don't go to that restaurant anymore, or I don't go to that group anymore. I'm maybe not participating with, XYZ thing because I am embarrassed and people are frustrated that I keep asking for repetition, and I'm embarrassed that I keep having to ask for repetition. And people are notoriously not the best when it comes to good communication strategies. So there's a lot of things that really impact our other elements of our life that are correlated with hearing loss. When we think about specifically people who are working with hearing loss, I found some various interesting pieces of information about this, but we know that people who have hearing loss actually have higher rates of unemployment, and that's pretty significant. There's also significant correlations with income potential. There's been lots of studies that have looked at that and found that people that have hearing loss are not as likely to have the same level of income as their peers that don't have any trouble with hearing loss. I see a lot of veterans in our practice, and I remember one veteran in particular that we were talking about. He had some specialty things that he was exposed to while he was in the service, things that correlated with his job as a civilian. And he was very happy to have that skill set to be able to kind of propel him into that career. But he had a significant hearing loss. And at the time, just, wasn't really comfortable with, kind of seeking treatment. He was concerned that at a younger age, people would be very judgmental. There's a lot of stigma that may be attached to that for some folks. So he decided that he didn't want to pursue any kind of treatment, but he was thinking back on this, and he had retired about 20 years before, but he was very disappointed that he felt like he missed out on opportunities for being able to be promoted or take on different kinds of projects. There was even a point that he was considering a change in career, but he was really dissuaded internally from seeking that because he was not able to participate fully. So there's a lot of aspects of hearing loss that can be very challenging for people who are working or who are trying to gain employment, and being able to make sure that they are able to succeed in the various settings that they are, really working in or trying to work toward. When we think about somebody with hearing loss, we want to make sure that we are able to assess those needs, like I mentioned, but also offer them whatever treatment solutions are appropriate for what their goals are. So that can look like lots of different things. It might be technology. It may be something like a hearing aid or a cochlear implant, a bone anchored hearing aid, maybe other kinds of assistive devices. It might be something else. It might be working with sign language or other types of auditory or verbal strategies. It might be a combination of the two. So knowing what their goals are and knowing what's going to be important to them to be able to help make sure that they are successful is really important. We know that regardless of where somebody falls with that, there are a lot of things that we can do to help improve communication. So this is just some kind of quick tips, but one of the big things is looking at somebody. It frustrates me when somebody comes in with a spouse, and the spouse, they maybe get fit with hearing aids, and the spouse says, well, don't look at me. they want to test them and see how well things are going. Well, everybody does better if you're looking at them. Yes, there are certainly situations where you don't have an opportunity to look at somebody, but for the most part, when we're engaging in a conversation, we're engaging those good listening skills, we're looking at them, we're looking at their face, we're getting that body language information, we're getting those lip reading cues. Even folks who are insistent that they don't read lips, we all get those kind of context clues, or we just may not be aware of the fact that looking at somebody's mouth gives us a little bit of information about what's being said. So looking at somebody, facing that person, trying to speak normally. This is also one that's challenging. A good rate of speech is important, but speaking excessively slowly is not going to be helpful. You don't want to be super fast and you don't want to be super slow, because both of those can be very challenging. Lighting is important, being able to see somebody's face, not impeding your mouth, right? So people that are putting their lips or putting their fingers on their lips, or chewing gum, smoking, there's lots of things that can impede our ability to understand speech. Improving our signal to noise ratio. If you are in a situation where you are trying to convey directions or trying to communicate with a client or patient or whoever it is, you're going to be able to do better, and that other person is going to do better if you can minimize the amount of noise in their room. There's less distraction for their brain, and there's also less competition for what we're trying to be able to actually hear. When we think about new technology, there's lots and lots of new things that are perpetually coming out. That's also a really exciting element of this field, is that, typically there's new technology or new updates to technology that rolls out every 6 months to a year. There are appreciable changes at least every year to 2 years on the different chips. I have just touched on a few of these are the major manufacturers and some of the new technology that they have brought out over like the last year or so. And the different manufacturers definitely bring different elements to the equation. Ultimately, being fit with something that is done utilizing best practices is going to be the most important, right? So I always say, it doesn't really matter what brand if somebody comes in and sees me and has hearing aids, or we pick, because if I'm fitting them appropriately for their hearing loss and, the size and shape of their ear canal, if I'm running real ear measures, if I'm verifying that with, subjective outcome measures, there's lots of success that somebody can have regardless of what the brand is. But there's a lot of cool things that are out there, and it really just depends on what the patient's needs are. So having a really thorough needs analysis helps us to direct the patient to the technology that we think is going to best serve their needs. And we do work with all the major manufacturers. Not everybody does that. It does require kind of an extra level of dedication to maintain your ongoing education and make sure that you feel comfortable with that. You also have to stock lots of different things. So of course, every manufacturer has their own specific parts and tools that they want to be able to utilize for patients, but being able to offer a wide variety of technological options is really important so that we can make sure we find the best match for those patient needs. That also looks like technology with accessories. So sometimes a patient is in a really challenging environment and a hearing aid by itself isn't going to cut it. They may need a microphone. Like from one of the major manufacturers, Phonak, they have a line of special microphones that are called Roger. And there's lots of ways that these can be utilized, but one might be a tabletop microphone. So they can put that microphone in the center of the table. It utilizes beamforming technology, so you can turn on different kind of directional beams or all of them. If they're in a big meeting where people are talking from lots of different areas, that makes a huge difference in helping to further improve that signal to noise ratio. It might be using an app on their phone. Most hearing aid, I'd say probably every hearing aid manufacturer, even kind of like outside this range of the big ones, offers an app that you can use as a remote if you have a smartphone. So being able to adjust that on the screen is really nice, especially because it's hard sometimes to find the button or feel that on the back of the hearing aid. So having that adjustment where you can see what you're looking at makes a big difference. Being able to stream technology, if somebody's on the computer all the time and they're doing maybe a Zoom meeting, or they take calls from a customer, having something that can translate a signal through their hearing aids is going to help them be better. And maybe having a microphone that they wear so that when they're speaking, they don't have to wear a headset or put a phone up to their ear. They can utilize that improved audio through the devices, and the other person is still able to hear them, through whatever means they need to. Being able to utilize rechargeability. That's a big one. I would say the majority of our patients really, really, really value rechargeable instruments. because it helps with not having to remember batteries and making sure that if they have any kind of dexterity issues, we can make it a lot easier for them to be able to still utilize those devices for as long as possible. There's lots of stuff on the list, and I know I'm running a little bit long. I apologize, guys. The last thing I wanted to touch on was oral rehabilitation. And this is certainly like it's last but not least. When I talk to patients about hearing loss and treating hearing loss in different ways that we do that, I will frequently use the analogy of physical therapy and a knee replacement. If somebody has a knee replacement, you're not just going to have that in isolation. It's going to be paired with physical therapy. When you have hearing loss, if you decide that you want to treat the loss with hearing aids or other types of assistive devices, it really shouldn't be done in isolation. It should be paired with oral rehabilitation therapy. That lets us really improve the way that the brain functions, improving our ability to understand speech and noise, filling in contextual cues, processing faster rates of speech. Those are things that are all really, really important. So we want to try to give our brain the most resources that it possibly can have. And there's options that utilize technology. There's options that don't need any technology, things people can do right just with stuff that they have around the house. I've listed some of those out there. I do have a really nice handout that we give to our patients that summarizes that in more detail. And that is something that I'm certainly willing to share if anybody has any questions. So to that end, again, I appreciate the ability to speak today. If you have any questions, certainly feel free to reach out to me. I have my email address on the screen. If you want references for anything, feel free to reach out and I'm happy to send those on to you. We want to be able to help you guys be able to serve your customers the best they possibly can and whatever that looks like. Thank you.
And we do have one question that was in the chat. And the question is, and I think this is from the MRS, Michigan Rehabilitation Services perspective, and we have people in the audience today that are from MRS and from the community, but this is from the MRS perspective. As an audiologist, how do you feel about receiving an audiogram from another provider and then asked to make a recommendation for a hearing aid? Have you experienced this?
Yep, certainly.
I think it's just asking, in your professional opinion, what do you think about that?
So I don't have a problem with it as long as I know it came from a reputable source. If it was something that was done in, the right time frame, right? So it's done in like the last 6 months or year, and we know that there haven't been any perceived changes. If they did, kind of the full range of testing, like I talked about before, so that I have, a complete audiologic picture to look at. I'm still going to do a history with patients. If I need to do supplemental testing, I will. But if I know that it was conducted utilizing best practices and that it's a reliable audiogram, I personally don't have a problem with that. I'm happy to be able to use that so that patients don't have to have another hearing test if they have one that's appropriate.
Okay, and then we got another request for the oral rehabilitation resource, and I think that we have an email, so I believe that we will be able to send that to that person. And that is it for the questions from the chat. Monica, I will turn it back over to you.
Thank you, Kathy. Thank you so much, Dr. Bogue. I really appreciate your time today. And thank you everyone for hanging out to listen to Dr. Bogue's presentation. As a counselor, Dr. Bogue really helped me understand the significance of, the brain and the interaction with the hearing, some of the physiological and psychological components that impact our customers in their day-to-day lives and their work lives. And it just really helped kind of gel my understanding about the hearing aid process. And bless her heart, she also survived the AudioNet days with us. So we appreciate your time today. And again, if anybody has any questions, don't hesitate to reach out to Dr. Bogue or myself, and we'll be happy to get you connected with additional resources or answers to questions. Thank you for your time today, everyone. Have a great weekend.
Thanks, everyone.